So I find the word thyroiditis very confusing because you can talk about pathologic thyroiditis and the clinical syndromes. So whether you're talking about pathology or clinical syndromes, all of them are characterized by thyroid inflammation, whether it's clinically evident or visible to the pathologist. But I'm going to talk about first the clinical syndromes and just give you 2 slides on pathologic thyroiditis. So when we're talking about a clinical syndrome, we're talking about any sort of transient change in thyroid function. And the way we tend to categorize thyroiditis is by the absence or presence of thyroid pain. When we talk about the pathologic definition, this patient can have absolutely normal thyroid function or abnormal thyroid function, but you're talking about the presence of lymphocytes, generally B cells and cytotoxic T cells in the thyroid, which is the etiology of Hashimotos. So we're first going to talk about the clinical syndromes, and we'll start with the one that has no pain, painless thyroiditis, which, as you saw in Navoda's talk, is not the most common etiology of thyrotoxicosis. It's about 1 to 5%. And generally, we talk about this occurring either postpartum or sporadic. Both of these are autoimmune, and we will talk about drug-induced because it's important. So what happens? There's this transient thyrotoxicosis caused by the leakage of stored thyroid hormone, and so you become transiently thyrotoxic, but then there's nothing left to leak out, so you are then hypothyroid for several months, and you generally return to euthyroidism. So this is a figure from Elizabeth Pierce's review over 15 years ago that shows you here in the hyperthyroid, or the thyrotoxic phase, it's transient with an elevated total T4. If you were to do a scan, there's no uptake because there's no production, there's leakage. And then this lasts for, you can see, about 2 months. And then you develop transient hypothyroidism, where the TSH goes up, shown in blue, the total T4 goes down, shown as red. And if you were to do a scan at the time the TSH is elevated, you will see return of uptake in the thyroid, and often actually an elevated uptake, even though the patient is euthyroid. So let's first start with the case. And so here is our 30-year-old female who is postpartum and feeling tired and maybe feeling a little sad. She had lost her weight gain, gestational weight gain, but now has regained it. She has some hair loss. She's still waking up at night several times because the baby requires night feedings. It was an uncomplicated pregnancy, and she was told that her thyroid test was normal. Her mom, though, received radioactive iodine for an overactive thyroid. Her vital signs are normal. There's no alopecia. Her thyroid is slightly on the larger side and firm, non-tender, with normal reflexes. And these are her thyroid studies. Her TSH is 42. Her total T4 is at the lower limit of normal with a lower T3 uptake if that is what you do, and her free T4 was below normal. So this is a woman with overt hypothyroidism, but most likely represents the occurrence of postpartum thyroiditis, which is this transient thyrotoxicosis or hypothyroidism that occurs in that postpartum period in women who were previously euthyroid. Now, sometimes you don't see the classic thyrotoxicosis followed by hypothyroidism. About a third have that. But often you miss the thyrotoxicosis because it happens early after delivery, and you're catching the woman in the hypothyroid phase. This is the same as painless thyroiditis. So when you have a patient who has transient alteration of thyroid function, but hasn't just had a baby, except by definition, this occurs in the first year postpartum. So the definition is the 12 months after delivery. The prevalence, there have been a number of studies worldwide. It can vary between 2 and 18%. I could throw up a figure that showed you a map of many countries. But if you want to identify those women at highest risk, it's women who have evidence of thyroid autoimmunity, as well as those women who have other autoimmune disorders, such as type 1 diabetes, rheumatoid arthritis. And importantly, if it happened to you in one pregnancy, there's an 80% chance it's going to happen in the second pregnancy. So what do you have to do? Well, Graves' disease can present in the immunologic rebound postpartum, so you can't always assume that thyrotoxicosis diagnosed in the postpartum period is simply postpartum thyroiditis. Clinically, however, the thyrotoxicosis from postpartum thyroiditis is usually less than 6 to 8 weeks. So if it's going on longer than that, you might consider Graves'. Clinically, You don't generally see orbitopathy, there's no pretibial myxedema, and the thyroid is not enlarged. So if you have a Brui and an enlarged thyroid, that is more likely to be Graves'. And certainly, as we found out earlier this morning, you can check TSH receptor antibodies. They should be negative in postpartum thyroiditis. But remember, both Graves' and postpartum thyroiditis are a spectrum of immune disorders of the thyroid. So TPO antibodies are going to be positive. The radionuclide scan. Well, you try to do that if someone is not lactating. If someone is lactating, you can usually sort this out clinically. As you know, I-123 is generally safe, but it's not a good idea to give it when someone is lactating, and you can generally sort out the difference by the TSH receptor antibodies, the physical exam, and the history. Since there isn't increased production, you don't treat with antithyroid drugs, but you can give beta blockers if necessary, and generally this resolves, and you treat with levothyroxine if they're symptomatic. So pretty classic, and something that I think that is very important generally for our obstetricians and our GPs to understand and recognize, because they're the practitioners who are seeing these patients in the postpartum period. So prevention, is there something we can do where if, let's say, we identify a woman who had a previous episode of postpartum thyroiditis, where she's at very high risk, or we know she's antibody positive, can we prevent this from happening? And unfortunately, we can't with levothyroxine or iodine. Those have both been studied. Selenium has been studied in 2 randomized controlled trials because it's predicated on the known observation that if you treat patients with selenium, thyroid antibodies can decrease. However, there's a pretty recent meta-analysis that has shown that there's no consistent effect of selenium to show differences in clinical symptomatology, even if antibody levels may decrease. So at this point, there's no prevention of this. It's education and monitoring, detecting someone when they're thyrotoxic, treating them with beta blockers, provided it's not Graves' disease, and then following them for hypothyroidism. And future risks, this is really the education. These women will have a higher likelihood of having this again with subsequent pregnancies, and it's really the hypothyroid phase for all of us who've treated these women that can be very burdensome and really impair the quality of life, and that's what we need to treat. I have sometimes seen practitioners say, your TSH is 100, it is going to get better, you do not need to treat this. I don't understand that response. And that's not something I think any of us should accept. It's going to get better, but you can treat them transiently and stop the medication. So not everyone recovers from the first episode, and people can remain hypothyroid after the first episode. And long-term, because there is autoimmune thyroid disease, they can develop permanent hypothyroidism, and so you do need to monitor them. So this is pretty much the classic postpartum thyroiditis and also autoimmune painless thyroiditis. So something we need to be aware of, mostly because by the time we see them, the thyrotoxicosis, which is transient, is hopefully getting better, but we really need to follow and treat them in the hypothyroid phase. I'd like to spend most of the time talking about drug-induced thyroiditis, because I think this is where I know I saw many of you your Amiodarone is used in Sri Lanka. I've asked a couple of people, how many people have seen the endocrinopathies with checkpoint inhibitors? Are the checkpoint inhibitors being used by oncology in Sri Lanka? Is that yes? No? Pembrolizumab? You're not using them. They will be coming. So then it's very important to know about these for all of the endocrinopathies that can occur. So these are the 5 most common categories of drugs that can cause drug-induced thyroid inflammation: amiodarone, checkpoint inhibitor immunotherapy, kinase inhibitors, and the interferon alpha and interleukin 2. It's only with the interferon alpha and interleukin 2 where it's more likely to get thyroiditis if there's pre-existing autoimmunity. And the presentation is exactly like painless thyroiditis, a transient thyrotoxicosis that can then lead to transient or sometimes permanent hypothyroidism. But I'd like to focus on amiodarone. So amiodarone is a very commonly used drug. It sounds like even here in Sri Lanka, and I know certainly in India as well, for the treatment of patients with refractory atrial arrhythmias. And amiodarone has a lot of iodine. So if you remember back to my pregnancy slide, I said that the WHO and UNICEF recommend 150 micrograms a day of iodine in the non-pregnant state for a healthy adult. This is 6,000 micrograms of iodine, not 6 milligrams, it's 6,000 micrograms of iodine for every 200 milligram pill of amiodarone. An amiodarone load is 800 to 1,600 milligrams, so up to 8 times that. So, and then the daily maintenance dose of amiodarone is double that. So the daily maintenance dose of amiodarone, which is 400 milligrams, has 12,000 micrograms a day, so 1,000 times more iodine than is recommended for daily consumption. Now, this drug, not only does it have it, it'd be fine if you sort of excreted it in your kidneys, but it's lipophilic, so it gets stored in your fat. And the last speaker had just mentioned not doing uptakes for maybe 6 months after amiodarone. I have patients who have urinary iodines of 20,000 while they're on amiodarone, and a year later their urinary iodine is still 2,000. So I can't even do an uptake. This is a lipophilic drug, so it takes a really long time to excrete from the body, and especially for patients with more adiposity, more drug will be stored. So why do people have problems with their thyroid when they take amiodarone? Well, one thing is that the iodine depends on what your background thyroid is doing. So if you have some baseline autonomy because you have some borderline toxic or functioning nodules because you may be living in an area that is not iodine sufficient, the iodine, like anything, in that situation will increase the production of thyroid hormone because you'll be feeding these functioning nodules. So that if there's baseline autonomy present in a multinodular goiter, those patients can actually become hyperthyroid with increased production. The scenario that we see most often that we're going to discuss here is the toxicity to the follicular cells, which leads to a thyroiditis. And that can be what is very troubling and concerning to our cardiologists and to our patients because, as we all know, thyrotoxicosis can worsen atrial arrhythmias. And hence, if a patient also has heart failure and they become tachycardic, it worsens their heart failure. And it can even worsen ventricular arrhythmias, so that our cardiologists are very aware that someone who may be stable on amiodarone, if this happens with their thyroid, they can become decompensated. And even in our patients who don't develop thyroid dysfunction, amiodarone is one of the main causes for what we now call euthyroid hyperthyroxanemia. So patients who have elevated total T4 levels but normal TSHs because there's decreased 5' deiodination of T4 to T3. So in euthyroid patients, to compensate for the lower T3 levels that are being seen by the thyrotropes, the TSH goes up a little bit to increase T4 production, and then you get an equilibrium again. But we're going to focus on thyroiditis. So amiodarone-induced thyrotoxicosis is generally divided into 2 types. So the first one is based upon the fact that your background thyroid is abnormal and has some nodules with some autonomy, so multinodular goiter or potentially even Graves. And this is more common in iodine-deficient areas, which is generally not Sri Lanka, based upon those slides from the pregnancy talk. And so the iodine load actually increases thyroid hormone production, hyperthyroidism in these nodules, and you may have a detectable radioiodine uptake. It's not going to be elevated because these patients still have huge amounts of iodine, but you actually may get an uptake of 5% or 6%. I think the highest I've ever seen is about 6%. And you'll see it actually in the nodules. If this is related to Graves' disease, you will see increased vascularity on ultrasound. On the other hand, the most common type, and obviously part of the talk on thyroiditis, is type 2, induced amiodarone thyrotoxicosis, which is destructive. And this is where the gland starts out normal, and if you're antibody positive or negative, you are not more likely to develop this. This affects all thyroids. There is no uptake on radioiodine. If you check TSH receptor antibodies, they're negative. And importantly, the ultrasound shows decreased vascularity. So what we used to do in the United States before TSH receptor antibody titer levels became easily available was we quickly looked at ultrasound because it was an easy way to distinguish type 1 from type 2. So here's a 52-year-old man who was started on amiodarone 9 months ago for the usual refractory atrial fibrillation, and here are his thyroid function tests: an elevated free T4, an elevated but not quite as elevated total T3, because remember, there's still decreased conversion of T4 to T3, and this is his ultrasound. So you can see his thyroid here. It's minimally heterogeneous. There's no increased vascularity. Here's his right and his left lobe in sagittal views, and this is the vascularity. Now, very, very little increased in vascularity compared to something like Graves' disease, but it's very important that whoever is doing the ultrasound uses the correct settings for detection of thyroid vascularity, which is very different than the settings that are used for carotid ultrasound. So for those of you in the ultrasound course tomorrow, we'll go over those, but you want to make sure that this is set on the correct settings for thyroid vascularity detection, because if you use the settings for carotid artery detection, every thyroid is going to have low vascularity. So we do what's called a low PRF, or pulse repetition frequency, and a low wall filter, and that's what's shown right over here. The PRF on this image was 731, and the wall filter was low. So if you're doing ultrasound and you have questions about that and you're coming tomorrow, we'll answer them. Otherwise, I can answer them more a little later. But this is a low vascularity thyroid. But now we can get TRAB back pretty easily so that we can check this and we don't do ultrasounds very much anymore. So how are you going to treat this patient? So how many of you use methimazole or carbimazole? How many of you use prednisone? How many of you use perchlorate? How many of you use some combination of the drugs? So before we could get the TRABs back, and even now, often people will start both methimazole and prednisone because you don't know what this is, and you'll see in a second what happens. So he was treated with steroids, and let's say we had started him on both methimazole or carbimazole and prednisone. He was treated with steroids, and you can see between May 27th and June 7th, there is a significant decrease in his free T4, and it's even going down about 2 days later. So the general recommendation has been that if you don't have a way to distinguish between type 2, which is destruction, and type 1, which is Graves' disease, that you give both prednisone and methimazole, and then when you see this nice progression of thyroid function tests, because those of us who treat Graves' disease know it takes longer than this, you can stop the methimazole or carbimazole. Generally, you do have to be treated longer than just 6 weeks. The average time is about 3 to 4 months. And what you do is you can gradually titrate the dose down. Now, how much prednisone do you give? Well, there are randomized controlled trials that have certainly shown that giving prednisone versus perchlorate and other is the better way to go. But the recommendations vary. And you can give between 20 and 40 milligrams. Some people will dose it at so many milligrams per kilogram. Generally, if these patients don't have heart failure, the cardiologist won't be concerned about the higher doses. But often these are pre-transplant patients, and I'm twisting arms to even be able to give 20 milligrams of prednisone in that situation. So generally, the lowest we'll start with is 20, but we'll try to go a little bit higher. As I said, often if you can't distinguish whether it's Graves' type 1 or it's type 2 destruction, you can give both drugs and then stop the methimazole or carbimazole if it improves. The important thing is you don't have to stop the amiodarone. Sometimes these are very sick patients. This is the last drug option they have, and it can be continued, and there are actually now studies that have shown that there's a really small chance of recurrence within the first 5 years. So you can certainly do that. Some of these patients will become hypothyroid. And again, there are unusual cases. So sometimes when you're talking to your fellows and trainees, they may not respond to prednisone. They're TRAB negative, but you do need to give both drugs. And nobody quite understands that scenario, but it happens. And even occasionally you need surgery. So generally prednisone works, but there are those cases where you may need a combination of drugs and sometimes surgery. I'd like to review with you checkpoint immunotherapy because it's going to come here, because it's coming everywhere, and it's very, very effective for a number of solid tumors as well as for liquid tumors. So this is to remind you a little bit of the immune system. This is actually a lovely review on checkpoint immune therapy that we have all of our fellows read just so they can get up to speed with the oncologist. But what it's showing up on the top here there are T cells, and normally T cells have to recognize self so they don't attack self. So they have PD-1 receptors and CTL4 receptors, and generally our normal tissues will express these. And cancer shouldn't, because our T cells should be able to recognize cancer and then stimulate immune response. But what happens is, you can see right here, is either the antigen-presenting cells, the APC, or the tumor cells present the ligands to CTL4 or to PD-1. And what happens is, therefore, that our immune system no longer recognizes the cancer as foreign and can't attack it. So what happens is there are now drugs. Let me just go back to this. Other way. Here we go. So what happens is you would like the cancer cells to not express these ligands so that our immune system could attack them. We can't do that. So instead what the drugs do is these T cells then recognize the cancer as something that's supposed to be there and doesn't attack the cancer. So instead, we have drugs that provide antibodies that block the ability of our immune cells, the T cells, to bind to these ligands on the cancer, so that therefore our immune cells don't become exhausted and our immune system can attack the cancers. So there's PD-1 inhibitors, which are pembrolizumab and nivolumab. There's PD-L1, the ligand inhibitors, you can do that as well, and there's also CTL4 inhibitors. And for those of you who have not yet been exposed to this, there is a panoply of endocrinopathies that can occur, including type 1 diabetes, hypophysitis, most common with CTL4, hypoadrenalism, like primary adrenal failure, but the one we're talking about here is thyroiditis. And a number of patients, up to 6%, will develop this transient thyroiditis, more common with the PD-1 and the PD-L1 than the CTL4. The CTL4 are the ones that are more likely to give hypophysitis, and these patients present in Addisonian crisis because of ACTH deficiency. So when this does come, this is a time that we work very carefully with the oncologists. And this happens really quickly. It's incredibly quick. If you just use one drug, the median time might be around 5 weeks, but when patients are on combination, since they work by different mechanisms, we have patients where this happens as early as 2 weeks after starting therapy. So the way Amiodarone brought us together with the cardiologists, this has totally brought us together with the oncologists. And this is just from one review. It shows the typical time, when this can happen. So really early on, 5 weeks, they become thyrotoxic. They then come back to normal and they become hypothyroid. But remember, this can happen as early as 2 weeks on combined therapy. So a real case, 31-year-old, stage 3 ovarian cancer, was getting cisplatin and etoposide, so pretty normal drugs, but pembrolizumab, that's a PD-1 inhibitor. She got 2 doses, June 27th and July 18th. On July 31st, so remember I said double drug, happens really quickly. Thyrotoxic, tachycardic, her free T4 is off the wall. And look at her total T3. And it was just with these 2 doses. Now, for some reason, this woman had a thyroid in January 2018, which was 5 months earlier, and it's a little bit large. Her antibodies were negative, but otherwise the echogenicity is pretty normal. And this is what her thyroid looked like on August 1st. I mean, it's massive. I tried to show you the same scale, so you can see this is 4 centimeters. Her isthmus now is 1.5 centimeters instead of about 8 millimeters. And if you were to do an uptake scan, you can see there's no uptake. Her TRAb was negative, TPO antibodies negative. So autoimmunity does not alter a patient's likelihood of getting this thyroiditis. And you can see what was happened with her was she was started on prednisone and methimazole until the TRAb came back, because yes, you can also get Graves' disease sometimes with these drugs. The TRAb came back, it was negative. She was even started on cholestyramine to prevent the enterohepatic circulation. You can see that her T4, free T4 did not change. And she was really sick, and we sent her to thyroidectomy. By the way, this is a year ago. It was last summer, as you can see. Last summer, our entire endocrine group was the first time we'd ever sent someone to thyroidectomy for this. This was a very big decision. And this is her pathology. She's actually now been written up in the pathology literature. There are absolutely no follicular cells here. This is total destruction of her thyroid. So what you can see is some colloid. So you wonder, like, where did this thyroid come from? I mean, there was still colloid left that was being released. And basically, there's this, what they call a stromal response, and these are histiocytes, and there are some degenerative follicular cells. She did great. She's actually doing really well now, and she's on levothyroxine. And I've heard from others as well that the way we sometimes do have to send the amio patients for thyroidectomy, that's what happened here, but you can see what the thyroid looks like. Okay, painful thyroiditis. The two most common types are what we call subacute granulomatous decurvains viral or bacterial or infectious. And so let me give you another case. A 53-year-old woman, bilateral pain in her upper neck to her ears. We know that's where radiating pain comes from. She was tachycardic. Her thyroid was lobular and tender. You can see that her thyroid function tests were elevated. And let me show you her thyroid. You can see, although it's a composite image on the top, that she has diffuse heterogeneity throughout the thyroid on the transverse view and the right and left sagittal views. This is generally not very vascular. There's some minimal vascularity here. And it's not going to be vascular like Graves' disease. The challenge is, and if you stay for the Meet the Professor, is sometimes these dark patches get called as infiltrative nodules and somebody wants to stick a needle in them. But the key finding is the elevated sedimentation rate, which is shown here. Her ESR was quite elevated. And I think David told me he's going to show you a picture later of Dr. Quavain. But this is considered to be 5% of all thyroid disease. I would say 80% of my patients have no precedent viral URI. It is believed to be a viral origin. Sometimes it starts on one side and then goes to the other side. There can be systemic symptoms like fever and myalgias. The thyroid is exquisitely tender to palpation and sometimes unilateral if it starts on one side. The ESR is actually one time we probably do this test as endocrinologists, it's elevated. And generally, we give supportive therapy with NSAIDs. Very rarely, we need to use steroids. Generally, this gets better, and fortunately, most of these patients don't get hypothyroid. So this is what she looked like 12 months later. She was pretty much back to normal. We don't see this very commonly. The suppurative bacterial infectious acute thyroiditis is more likely in patients whose immune systems are not working perfectly because the thyroid, because it has all that vascularity, is generally resistant to infection. And it can be bacterial, fungal. There's been cases of tuberculosis and even parasitic thyroiditis. These patients are incredibly sick. I actually have only had one case, and that was in someone who was very immunocompromised, and it was bacterial. But you do gram staining and culture, and sometimes you have to drain, give antibiotics, and sometimes even thyroid surgery. And some of you may have more experience with this type of thyroiditis than I do. I'd like to end by just telling you a little bit about pathology, because we talked about the clinical syndrome of thyroiditis as transient leakage of thyroid hormone, thyrotoxicosis, followed sometimes by hypothyroidism, either painless, which is autoimmune, or drug-induced, amiodarone, and now you know about checkpoint inhibitors, immune checkpoint inhibitors, or painful. But often when people talk about thyroiditis, they're saying they'll do an ultrasound and they'll say there's evidence of chronic lymphocytic thyroiditis. What is it that we're seeing on ultrasound? So we know that Hashimotos thyroiditis, the cause of hypothyroidism, most common cause of hypothyroidism, is mediated by this autoimmune destruction of the thyroid cells that involves both humoral and cellular immune destruction. So we call it chronic lymphocytic thyroiditis. Lymphocytes are present. So just to show you a normal thyroid on the left and a Hashi's thyroid on the right. You can see the normal thyroid has a very thin isthmus. The Hashimoto's has a very thick isthmus of 1.7 centimeters. You can see the normal thyroid has that very bright white-gray texture. The Hashimoto's thyroid, and this patient has a normal TSH. She still has enough functioning thyroid on the right, has this heterogeneity. So I want to explore it a little bit further just to show you how ultrasound can give us an indication of what the pathologist will term as thyroiditis or lymphocytic infiltrate of the thyroid under the microscope. So there's the left side, there's the right side. So what I've done here is outlined the capsule of the thyroid, and you can see that it's interrupted as opposed to the thin white line on the left side. You can see over here there are some gray areas that are the same echogenicity as the normal thyroid, but there are many areas that are hypoechoic or darker, and these are not nodules. And it turns out that lymphocytes image as hypoechoic. And the third finding you'll see are these white lines, which are fibrosis. So let me show you Hashimoto's under the microscope, and shown here. So the first thing we talked about was the white areas look like the normal thyroid, and that's the preservation of the normal follicles that you can see circled on the pathology slide. The dark areas are where the lymphocytes are that allow through transmission of the sound, so they appear dark or hypoechoic, where the blue arrows are on the ultrasound. And here you can even see some germinal centers on pathology of Hashimoto's. And then the last thing we talked about was fibrosis, and you can see fibrosis under the microscope, and you can see fibrosis with the yellow arrow. So this is what a pathologist would term as lymphocytic thyroiditis, and the only way to know what the patient's thyroid function is to check the TSH. So I'd like to thank you, and I will end by showing you a picture of the Liberty Bell, one of the symbols of independence in the United States, housed in Philadelphia.